Well, I know I mentioned that last week's episode marked the end of podcast interview recordings for Season 2, and that we'll be opening back up for Season 3 in September. Well, I got to thinking, and rather than leaving our listeners with radio silence over the next month, I'll be going back through the archive and picking out several episodes that I wanted to circle back to. And if you're a new listener to the podcast, you maybe haven't even listened to some of these episodes yet. In addition to re-airing our original interviews, I'll be providing some additional thoughts to lead off each one of these episodes. And as always, to our listeners, if there are any topics you want to hear that we haven't covered yet, or anything you want to hear more of, feel free to email us at support@prostatehealthpodcast.com, or just pop into our Prostate Health Podcast Facebook group and post your thoughts in the group. So looking back to episode 29, when it comes to prostate enlargement, we focused on the importance of preserving your bladder health. I think this topic really hit home with a lot of our listeners. What a lot of men and their loved ones don't realize is that by ignoring symptoms of an enlarged prostate, that damage may be occurring to the bladder and affecting their overall bladder health. And this is something that I come across in my practice on a day-to-day basis. Many men already with noticeable damage to their bladders by the time they get in to see me for their initial consultation. And that is why I felt it was so important to circle back to this topic. And we'll be looking at some of the potential symptoms to watch for, but also how we are continuing to see a shift in the treatment of an enlarged prostate. So stay tuned. The show today is brought to you by our sponsor, the Prostate Health Academy. The Academy is an essential community for individuals wanting to learn more about prostate conditions, connect with like-minded individuals, and transform their overall health. We just granted early Academy access to those on our waitlist. Well, in case you missed the opportunity, for our loyal listeners of the podcast, we are granting early access to our podcast listeners as founding members of the Academy before our big launch. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. Again, that is www.prostatehealthacademy.com and click on Join Now. We'll see you on the inside. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. So I'm excited to have Dr. Elizabeth Mobley joining us today on the Prostate Health Podcast. Dr. Mobley is a board-certified urologist with Urology Austin in Texas. She pursued her urology training at the University of Utah and following residency, completed additional urology fellowship training at North Shore Hospital in Auckland, New Zealand. She enjoys working with both male and female patients, and she prides herself in being able to offer a variety of treatments to various conditions. For example, for BPH or enlargement of the prostate, she is trained in a variety of techniques such as UroLift, transurethral resection of the prostate or the TURP procedure, Greenlight Laser therapy, button vaporization therapy for the prostate, and robotic simple prostatectomy. She was the first female urologist in Texas to receive the UroLift Center of Excellence, which is a designation for the UroLift procedure, and it was actually the third worldwide for this distinction. She is also the first female urologist in the U.S. to be named a NeoTract Faculty Member, consulting and proctoring urologists across the country on best practices when utilizing UroLift for enlargement of the prostate. Dr. Mobley, welcome to the Prostate Health Podcast.
Thank you so much for having me.
So Dr. Mobley, when it comes to symptoms of an enlarged prostate, what are some of the more common complaints you hear from men in your practice?
The most common issues that patients discuss with me are weakening of the urinary stream or slow flow, hesitancy of urination, the starting and stopping of their urinary flow, waking up multiple times at night to urinate. We call that nocturia. And we also see urinary frequency or urgency of urination be common complaints that can indicate that there may be an enlarged prostate going on. One of the other common symptoms that we hear a lot about is post-void dribbling. And that means that when they're done urinating, they sometimes have a little leak of urine afterwards, usually when they stand up and are walking away to go wash their hands.
Yeah, certainly very distressing, and quality of life issues as well when we talk about some of those symptoms. So in my practice, I have a lot of men tell me that they just write some of these symptoms off as, this is just a normal part of aging. They feel like they're just going to put up with the symptoms. I'm guessing you hear this from your men as well in your practice.
I do. I hear this all the time, and I try to educate my patients that this is not necessarily a normal part of aging, and that there's many things that we can do to evaluate the problem to determine the etiology, and also various, multitude of different treatment options, really depending on what the etiology is. And in fact, it's not really a normal process for men to have the majority of these symptoms. There is a component of aging of the bladder, but typically that would lead to overall milder symptoms. But when the symptoms are more significant, there are generally some underlying pathophysiological problem going on that needs further, evaluation and management. So whenever a patient comes to me and downplays their symptoms, I try to educate them on why it's important that they not sort of just brush these things under the rug, because there can be some detrimental long-term side effects if these things go unmanaged.
Now with that, the concept of bladder health and the relationship to benign prostatic hyperplasia has really become a hot topic, as you know. So for our listeners, what are some of the potential consequences to bladder health from long-term bladder outlet obstruction from an enlargement of the prostate?
As the prostate enlarges, the urethral channel, which is the urinary channel between the bladder and the outside world that people urinate through, the urethral channel runs right through the prostate, and the bladder thickens to try and help sort of compensate for that narrowing of the channel, and that can lead to overall bladder decompensation. It can lead to bladder wall thickening and trabeculation, which is something that we see on internal assessment of the bladder. It can lead to outpouchings of the bladder called bladder diverticulum, and those tend to not empty very well because there's no muscle behind that area of the bladder mucosa to help force the urine out. We can see patients then start to develop problems with incomplete emptying. And when you're not emptying well, the cycle of urinary frequency and maybe urgency will propagate upon itself and become worse. We can see development of urinary tract infections, bladder stones developing. And in really bad scenarios, when there's legitimate retention of urine where the bladder's just not emptying very well at all, that can affect the kidney's ability to make urine and pass the urine down the channel from the kidneys to the bladder, and that can cause swelling of the upper urinary tracts and renal function deterioration. So there are a lot of downstream side effects of the incomplete bladder emptying as a result of enlargement of the prostate or some other downstream bladder outlet obstruction.
Now, from a pathophysiology standpoint, what are your thoughts in terms of, you mentioned some of the changes we see, in terms of maybe why some of these changes might be occurring in the bladder with these men?
Right. That's a really good question. And my, research into why this has happened has been very helpful in me understanding why it's so important to educate my men. And so I'm glad you asked that question. Essentially what happens is when there's bladder outlet resistance or an obstruction, again, distal to the bladder neck, and that can be prostatic obstruction or scar tissue, or urethral stricture, meatal stenosis, any sort of obstruction, the bladder develops compensatory hypertrophy. And the bladder muscle is a smooth muscle, and it's different from other muscles in our body, like our biceps and our quads and our traps. Our bladder is very much like our heart. These are smooth muscles, non-striated, and they serve a very specific purpose, and their main purpose is contraction. And the properties of the bladder and the heart, for instance, they're very elastic, so they can expand and contract. They don't like to have to contract under high resistance. And when they do, as in with men getting bigger prostates blocking that channel, what we see, and we see it very quickly, is we see increase in the weight of the bladder. We see neoangiogenesis. We see initially an increase in blood flow to the bladder, but over time we see decrease in the blood flow to the bladder. that causes ischemia. The body senses that there's something going wrong and it sends cells in to try to fix it, but it lays down collagen. And the type of collagen that's laid down is not elastic. So it doesn't expand and contract like normal. So over time, that leads to what we call a decrease in compliance. And the bladder just can't physically hold the volume that it used to without higher pressures being generated inside of it. These higher pressures can lead to that sensation of needing to urinate more often and with more urgency. And also because the bladder is not as contractile as it used to be because of this collagen that's laid down, we start to see inefficiencies in the ability to void. So we start to see a rise in what's called the post-void residual. That means when you go to empty, your bladder doesn't empty its full contents. So then you're not always empty. And like I equate to, like a tank of gas or a glass, if it's never empty, then it doesn't take long to get full again. Then you have to go more often. And so basically this cycle just propagates on itself. And essentially, if you really want to get down to the meat and bones of it, if you look at the morphological changes, we see the structure of the bladder muscle cell change. And it changes, as I described above, in patients who are obstructed. And we also see decreased innervation. That means the nerves that supply the signaling to the bladder to contract and relax. We see less innervation to bladder muscle that's been obstructed. In the aging bladder, but the bladder that's not obstructed, we see normal morphology. We do see decreased innervation as the bladder ages, but we don't see those morphological changes where you have more of the collagen deposition and the thickening of the bladder muscle cells. So, the fact that some patients will have some deterioration of their bladder function over time as they age probably doesn't explain the vast majority of symptoms in men and the incomplete emptying that we see in men who are aging and are also obstructed. Does that make sense? That's
an excellent explanation. And I kind of love how you used the comparison to the heart, and I sometimes use that too. It's, unlike your biceps and other muscles where, it's a good thing to work against resistance, the heart and the bladder, they don't like working against resistance. It's a bad thing.
Right, exactly. And some of my patients who are kind of struggling to understand that concept, I do mention to them, you've probably had friends or family members that have developed congestive heart failure. It's the same sort of scenario. The heart just can't keep up with the amount of blood and fluid that's coming to it to be pumped, and it just can't process that amount. Same thing happens with the bladder. And in the bladder scenario, when the bladder muscle decompensates and you stop emptying very well, you can develop acute and or chronic urinary retention. And those patients, unfortunately, become catheter dependent. And if we get to them too late, so if they come to us and they're already at that point, there's a very high chance that no matter what we do to try and get them unobstructed, that bladder muscle function has already been impaired so much that we may not be able to help them in the same way that we would have been had we gotten to them years, months, we don't really know that timeline, but, presumably years earlier.
Now, my next question, we kind of covered a little bit already in terms of what are some of the potential complications that can occur due to this enlargement of the prostate. I know you mentioned that just not being able to void or retention of the bladder where it just stops working. You even mentioned earlier in terms of it even backing up, affecting the kidneys. Any other potential complications that we sometimes see in terms of this bladder outlet obstruction?
Yeah, so those are the main ones, but it's going to be anything, the real complications that we see are related to the fact that the patient's not emptying their bladder well. And so at the outset, when it's more of a incomplete emptying as opposed to full-on retention, patients may have the odd urinary tract infection. And males they shouldn't get urinary tract infections. Whenever a male has a urinary tract infection, you got to start wondering, is there some underlying reason that's increasing his risk for a UTI? A male needs a workup for that. So urinary tract infections, bladder stones, and that's basically like a big calcification in the bladder that develops when patients aren't emptying their bladder all the way. You get stagnation of the urine, and the components of, calcium and oxalate and phosphorus, uric acid, even in some scenarios, they can come together in that more concentrated stagnant urine and form a calcification. Those can cause a lot of bladder irritation. Sometimes you can see visible blood in the urine, and that may be related to bladder stones or urinary infections, or sometimes just full-on distension of the bladder. It stretches the bladder out so much, the little tiny blood vessels that feed the mucosal surface will sometimes rupture. We see acute urinary retention, and that means, all of a sudden the patient can't urinate, and they tend to end up in the emergency department getting a catheter put in. And that can also happen in the setting of more of a silent chronic urinary retention. So some patients are urinating, but they're urinating very often in very small amounts, and they're basically just able to urinate right off the top, but they're never really emptying a substantial amount of their urine. So those are kind of our silent chronic urinary retention patients. Those are the patients who are definitely at risk for upper tract. And what I mean by that is the ureters and the kidneys. The upper urinary tracts becoming affected by this decompensation of the bladder, and they can get swollen. You can get retention of urine back up into those ureters. That can affect the kidney function. And in severe scenarios, we can see renal insufficiency and even renal failure related to this. So obviously that's a very drastic scenario, but to say that I haven't seen it multiple times would be a false statement. I've seen it even in 40-year-old men. So, again, that's pretty drastic for it to get to that point. Most patients are thankfully caught before it gets there, but that's the natural history of this problem if it goes unchecked.
So when talking with these men in your practice, how does this conversation go in terms of counseling them, when they come to you with these symptoms, in terms of, what the next step is and what to do?
Definitely. Yeah, I love having this conversation with men because a lot of times they look at you like, wow, I've never realized how big of a deal this was, and nobody's taken the time to explain it to me, and it all clicks for them, and they actually then become very involved in their own health, and they want to take the steps to sort of figure out what's going on with them. So when men come into my office, I generally have them fill out the IPSS symptom score. That stands for the International Prostate Symptom Score Index. And I use that to try to understand what symptoms they are experiencing. Even if they don't come in to see me for that reason, I have them fill that out so that I can make sure I'm not missing an opportunity to help someone who may not realize that they're in trouble. And essentially, that symptom score tells me how often do they feel that they're not emptying well, they're having urinary frequency, hesitancy, weak stream, waking up at night, etc. So I look at that entire score, and then I specifically look at the individual parameters to try to understand, are they experiencing more of an obstructive type problem? That would be the weaker stream, slow flow, the dribbling, the incomplete emptying. Are they experiencing more of an irritative problem, which is the frequent urination, the urgency, and the nighttime urination? And then once I kind of understand that and make sure I'm getting what they're telling me and I'm not sort of mixing up their symptoms for something else, I explain to them that really one of three things in broad categories is going on. They do have an obstructive problem, which is going to be more often than not a prostate issue, or they could have a bladder problem. And you can have bladder dysfunction that leads to overactivity during filling, underactivity during emptying. And that can be primarily a bladder problem that really has nothing to do with the outlet, or it could have developed as a result of an outlet problem or an obstructive problem. And that is a very common scenario in men whose symptoms are pretty severe. And so I kind of break it down into those three broad categories and explain to them that probably the best thing for me to do to help fully understand what's happening in their specific scenario is to do a workup. And I offer those male patients a cystoscopy, which is where I pass a small flexible camera in through the urinary channel to evaluate their urethra to make sure there is no scar tissue anywhere. I find that, probably one time out of every 30 or 20 that I'm looking. So it's not that common, but I found one yesterday in a guy who I was convinced had a prostate problem, but he's got a very narrow stricture in his urethra, and that's probably what's causing his symptoms. So it's worth looking for that. I'm also evaluating the prostatic anatomy to understand, are the lateral lobes of the prostate, those are the parts that grow into the urethral channel. Are they touching in the midline? Is the patient having to urinate through a little tiny window through the prostate? What's the angle of the urethra through the prostate as it enters into the bladder? Is that a really steep, high angle? Call that a high insertion of the bladder neck. And then when I evaluate their bladder, I'm looking for trabeculations. I'm looking for cellules. So cellules are small outpouchings of the mucosa into the bladder, the hypertrophied bladder muscle or the thickened bladder muscle that we see as a result of outlet obstruction. I'm also looking for diverticulum, which is where the muscles basically become so thin it's split and the mucosa bulges behind it. I'm looking for any stones or any other issues like bladder tumors. I'm always doing a thorough evaluation when I'm in there. And I also often do an imaging study of the prostate. Most often than not, it's an ultrasound of the prostate to really get an idea of the total size. Though if they've already had some other imaging study that I can use that I trust, I don't necessarily put them through that. But I offer them as an opportunity to really understand what's going on with their anatomy. And I try to explain it in a way that they want to engage in that workup. And oftentimes the men, when they see their picture of the prostate on the screen, because they can all see what I'm doing, it's like, boom, they get it. They can see, oh yeah, now I understand why I'm urinating so slowly. It's just like if you're trying to blow air through a McDonald's big gulp straw versus a little coffee stirring straw. It makes sense, that if you're urinating through this little tiny channel, your bladder's going to have to work really hard. It's going to tire out, and they can see it. And seeing it, making it more of a tangible thing really impacts patients. So I do that often, and I do that early in the workup to, again, buy involvement on the patient, and so that I can really understand that I'm targeting the right issue.
And I think that's so important for them to be able to see it, and not only just the prostate. I'm sure you're sitting there showing them, some of those bladder changes too, if they have them.
Definitely.
And that really kind of really opens their eyes to, there's something really real going on here.
Definitely. And I will say this, again, going back to a patient that I saw yesterday, I was his second or third urologist that he's seen. He came to me specifically because he's interested in a UroLift, and he hadn't been offered that in the past. And he had records that showed that his bladder was fine and his prostate was fine, but his symptoms didn't seem fine. And so I said, I can use your ultrasound because they happen to have a picture saved of that, but I'd really like to do the cystoscopy myself if you'll let me. And I know no guy wants that to happen. They're not coming in there begging for a cystoscopy, but, please let me do it, because oftentimes what I see, what I'm looking for is not mentioned by a prior urologist, or maybe they haven't recognized it, or maybe they're just not comfortable with this actual problem to know really what they're looking at. And sure enough, I look in there and his prostate's massive. He's got a very narrow channel, and he's got cellules and diverticulum, and he could see him. He goes, "What are those two holes right there?" I said, "Those are diverticulum." "Well, how come nobody ever said that to me before?" I said, "Well, maybe they just weren't, kind of looking for the right things, or maybe they're just not comfortable with the problem." So for me, it's really important for me to see that. But then the guy, you know what he said? "I didn't want you to do that, but this was totally worth my time, and I'm so glad I did it." And I get that all the time, because I do take my time with the patients, and it's not necessarily just about the cystoscopy. It's about the whole talk that I have with them, explaining their symptoms, why they might be having them, why it matters. I get the same thing when I talk about medications and medication side effects. And patients are on these medications for enlarged prostate, and there's lots of side effects associated with them that they never knew could be really related to the medication. So that's something that I also spend a lot of time talking to patients about.
Well, we are going to take a quick break with a word from our sponsor. Then we'll be right back. Prostate Health Academy is an essential community for individuals wanting to dive in even deeper and learn more about the latest technology and treatments available to them for prostate conditions. In the Academy, you'll be able to interact with like-minded individuals in the private community forum and have access to exclusive bonus podcast, member-only video content with experts, innovators, and leaders in the field. We'll also be keeping you up with the latest evidence on a prostate-healthy diet and activity, and creating a roadmap to keep you on track. We just granted early Academy access to those on our waitlist. Well, in case you missed the opportunity, for our loyal listeners of the podcast, we have decided to also grant early access to our podcast listeners as founding members of the Academy before the big launch. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. We'll see you on the inside. Now, that patient that you saw the other day, I know he seemed pretty well educated coming in, kind of knew a little bit what he wanted already, but, for somebody that, that had those findings on cystoscopy, kind of how does that talk go in regards to, okay, this is what we found now, what are some of your options?
Treatment options, yep. Yeah. So it really depends. If a guy, there's a lot of factors at play that sometimes are a nuisance and sometimes are warranted, but insurance plays a role with everything and how we can stage some of these treatment options. But if a patient's never tried medications, sometimes they'll need to try a medication. If they have tried medications and the medications are not working, or if their insurance doesn't necessarily require that, sometimes we can move straight to an intervention. And when I say intervention, I mean a procedural intervention. The most common treatments to sort of deal with the prostate issue, which is primarily what I'm going to be talking about, are going to be deobstructive procedures. And there's minimally invasive treatment options, which can be offered in the office. And then there's more, I would call surgical treatment options, which generally are done in an ambulatory surgery center or a hospital. The minimally invasive treatment options are the UroLift system procedure. And that's where we use basically small little clips placed inside of the prostate to hold the tissue out of the way. So without physically removing tissue and without using any sort of thermal energy, we're just displacing the tissue so that we can create a nice open anterior channel through the prostate. And that, again, was built to be done in the office, and it typically is. In my hands, I do about 98% of them in the office. I do a few in the operating room when the anatomy is tricky or the patient is super anxious or nervous. But it's a nice office-based procedure that can be done with local anesthesia or sometimes some minimal sedation. And it typically goes very smoothly. It's relatively short procedure. Most patients go home the same day without a catheter and come back to see me a few weeks later, and they're already seeing significant symptom improvement. There's another office-based procedure called Resume, which uses steam-based therapy to treat the prostate tissue. And this can be done in the office as well, again, with some local anesthesia and a sedative if need be. And these tiny needles are passed in through a camera, similar to the cystoscopy that we do in the office, through a camera, and the steam is applied to the prostate. Most of those patients go home with a catheter for a few days. I don't do a whole lot of Resume, so I can't put an exact number on it anecdotally from my experience, but a few days of catheterization, just because the chance for some swelling after that procedure that could shut off the urinary channel is a lot higher. But that's also got great outcomes and is an office-based procedure. The surgical treatment options, there's quite a few. There's the transurethral resection of the prostate, and that's long been considered the gold standard of treatment options, though one may argue that, maybe there really isn't, there should be different definitions for gold standards depending on how invasive you want to get about the treatment option. But that one's been around for decades, and that is where an electrical current is applied through a loop typically, and the prostate tissue that's obstructing the channel is basically carved out piece by piece. And then all those pieces are washed out and you have a nice open channel at the end. That's typically, again, done at the surgery center or the hospital. You may or may not need a hospital stay overnight for something like that, just to have the catheter in place and some irrigation fluid running through it while all the bleeding sort of settles down. The recovery time on that tends to be a bit longer than on the less invasive procedure options, just because you have a completely raw surface area on the inside that has to heal. And while, towards the end, you may get equal or better symptom improvement overall, it's prone to more potential long-term side effects or complications than the minimally invasive procedures are. And there's Greenlight vaporization therapy, which is where a specific laser, and it's a Greenlight Laser, that's why it's called that, is used to ablate the tissue. And so you're not creating any chips. You don't get a pathology specimen out of this, but it's very hemostatic, meaning during the procedure, there's not a lot of bleeding. So it's great for men who may be on blood thinners or who have a very large prostate that tend to bleed a lot during a transurethral resection of the prostate. Those can work very well, and you can vaporize and ablate the tissue, or you can enucleate the tissue using that sort of a therapy. There's plasma kinetic energy that can be used to vaporize tissue. That's called the button procedure. There's now a robotic assisted, essentially a water jet therapy called aquablation, which is new. We don't actually have it yet in Austin, but we're getting some trials up and going here soon. But with that, the prostate is mapped out using an ultrasound while the patient is asleep. And then this high pressure water jet is controlled robotically after that mapping procedure, and it basically ablates the adenoma. And the adenoma is the technical term for the portion of the prostate that's enlarged and blocking the urinary channel. So that's pretty cool new technology. Again, most patients will need a catheter overnight for that. Sometimes there's some bleeding, especially in the larger prostates, and they need to be cauterized. And that means we use a little energy source to try and ablate any bleeding areas. And then for larger prostates, there are other techniques, holmium laser enucleation of the prostate, thulium laser enucleation of the prostate. These are two different types of lasers. And essentially, the tissue's kind of cut out from the outside in, essentially, with these minimally invasive technologies. It's all done through a camera through the penis. Those are great for large prostates. There's also something called an open simple prostatectomy or a robotic simple prostatectomy. These are typically used, these are bigger operations, maximally invasive, if you will, for really large prostates, but work fantastically well. Sorry, that was a long answer for that problem, wasn't it?
No, that was perfect. And, well, actually, for listeners, we'll be kind of getting into a little bit more in detail in terms of maybe, how do we kind of sort men into these different options, or at least, who may or may not be options, or who may or may not be candidates for some of these different options on our Prostate Health Academy that we're putting together. And we actually have a pretty good wait list of men wanting to join the Academy coming up. And we actually even have a episode coming up on the aquablation too. With Dr. Elterman.
I'll tune in on that one.
From Canada. So that should be a good one to look forward to as well. So lastly, for this episode, I just wanted to get your take on this as well. Now I see a lot of men who are referred over to see me, and they've already been on prostate medication, Flomax or Tamsulosin, some of the other medications. They've been on these medications for many years. And when we get into investigating the situation, like you mentioned, looking in their bladder, we already see these changes, trabeculations, these cellules, despite them being on medication for their prostate. And, I think we're starting to become more aware, that these medications may not be protective of the bladder and their overall bladder health. I just wanted to get your thoughts on that as well.
Yeah. So another good question and really good observation. So before we had medications, and, that's been a couple decades now that we've been using these alpha blockers and even the 5-alpha reductase inhibitors for prostate problems. We just had TURP, and we had a few other minimally invasive options that didn't work quite as well as TURP, but TURP was the go-to for men that came in with these urinary symptoms. And we actually didn't see nearly as much bladder deterioration as maybe we're seeing now. The alpha blockers have been shown to really reduce symptoms. They can help with symptoms, not to a huge extent for the most part, but they do help with symptom management. But as you alluded to, they really don't necessarily help preserve bladder function. At least there's not a documented study that I'm aware of, nor a lot of my colleagues that I've talked to about this. There is not a study that proves that these oral medications that we're using for this problem actually preserve bladder function. And we're starting to definitely see more men come in that are having, clinical symptoms and definitely signs on evaluation that their bladders are decompensating. And so we're starting to second guess, and a lot of us aren't just starting at this point. We're well into this second guessing here, whether or not these medications are actually serving the dual purpose that they need to serve, which is not only symptom control, but bladder health preservation. Can they prevent this compensatory hypertrophy from happening? Because that's where really the downstream sequela of and cascade of events happens that basically destroys the bladder. And unfortunately, my gut instinct on this is that, they're not, because I'm seeing too many men in my practice, and I know a lot of my colleagues are seeing it too, that are coming in despite being on these medications, still having progressive symptoms. It may slow the progression, or it may slow really the patient's ability to sort of be bothered enough that, the symptoms are better. So they're not cueing into the fact that maybe their bladders are worse off than they would have been had they not been on the medications, I guess. So it's taking them longer to present to us. And unfortunately, the bladder damage is already done. I have that conversation with men as well that come into the office and see me that are already on medications, and they say, yeah, I'm okay. It's helped me some. And then I just educate them so that they know that, look, we don't really have data that supports the fact that this is protecting your bladder. And so if you're only getting, mild symptom improvement on it, do you think we should maybe investigate whether or not there might be a better option for you? Now, with regards to UroLift, for instance, that data doesn't exist for UroLift either. I think they're working on it. It exists for TURPs, and it may exist for some of the other modalities that I mentioned. But definitely with TURPs, we know that patients who get a definitive deobstructive therapy, their bladder preservation long-term is much better than those who don't undergo that therapy. But not everybody that ends up getting a transurethral resection of the prostate or sort of extrapolating here, a deobstructive procedure will see improvement in their overall bladder function because, again, sometimes that damage is done and we can only preserve what's left.
Oh, I think those are excellent thoughts there. And so in summary, Dr. Mobley definitely brought up some very important points when it comes to BPH and potential side effects on bladder health, or potential effects on the bladder health, and how we are just really trending more towards trying to preserve bladder health with, some of these advanced therapies for an enlargement of the prostate. So Dr. Mobley, any final thoughts today for our listeners?
Yeah, I would encourage those of you that are listening that have been sitting here thinking to yourselves, yeah, I am experiencing some of those symptoms and I really haven't been too happy with my Flomax or Uroxetrol or whatever the alpha blocker or medicine of choice that you may be on. Maybe I should go ahead and go in and get that evaluation. And again, a lot of people are, as men especially, don't take themselves to the doctor very often. And if they hear that they're maybe going to have an ultrasound or a cystoscopy, I'm sure they think twice about it. But I would encourage them to at least come in and talk to a urologist about their symptoms, discuss what may be going on in their scenario, and decide whether or not that may be worth it for them to undergo that evaluation. Because, the vast majority of my men that come in that are nervous, at the end of the day, they say, well, that wasn't as bad as I thought it was going to be. And once they've actually gotten to their advanced therapy, be it a UroLift or a Resume or a TURP or whatever, they generally are going to be a lot happier. And you know what? 1 or 2 medications that they would otherwise be taking the rest of their life, we've gotten them off those medications and all the potential downstream side effects of those. So I would encourage men to be proactive with their health and take that step to find a urologist in their area that, seems knowledgeable in this sort of arena and make that visit with them just to make sure that they're not missing something which could long-term have serious, implications.
Well, it's definitely been a pleasure having you on the show today, and you've really instilled our listeners with some valuable information, and we really appreciate you taking time out of your busy schedule to chat with us. So thank you again.
No problem. Thank you again for having me.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/Prostate Health Podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.